The chair.
Oh, okay. Oh, okay. Well, good afternoon, everyone. I want to welcome everyone to Ramsey County Board Workshop. Today's workshop topic is Project Bridge. Courtesy reminder that this board workshop is recorded and it is live streamed on Zoom webinar. There will be no votes taken during this workshop. So let's start with introductions of commissioners and presenters around the table, then the rest of the room. Rena Moran, Ramsey County Commissioner, District 4.
Tara Jevon Singh, Ramsey County Commissioner, District 1. Mike Jog, Commissioner for District 6.
Garrison McMurtry, Commissioner, District 3.
Kelly Miller, Commissioner, District 7. Gloria Reyes, Deputy County Manager for the Safety and Justice Service Team.
Tim Vasquez, Superintendent at RCCF.
Nadir Abdi, Deputy County Manager, Health and Wellness Service Team.
Do you want to introduce yourself, Ashley?
Yeah, Ashley Bryant, Commissioner for Detention Services of the ADC.
Right, Lane Becker, County Manager. All right, why don't we start over?
Hello, Kyle Messett, Undersheriff Chief of Staff.
Right here, keep right.
Steve Morgan, Assistant Superintendent.
Amy Brush, Deputy Director of Facility. Liz Reed, Deputy Director of Field Services. The Incident Manager, Correctional Hall.
Dennis Staff, District Director of Field Services, Community Corrections. Ben Lewis, Deputy Director of Legal Services. Justin Featherstone, Assistant Superintendent of JDC.
Lily Ray of Lucia, Assistant Commissioner Director of Community Corrections. Monica Long, Director of Community Corrections. Alex with the Deputy County Manager.
And how to supervisor of Community Corrections.
Yes, Scott, Assistant Division Director for Field Services. That's really good chance. Great, how did you do that? Was that training the Misty South, manager from the Mayor's office. We lost with them.
All right, so welcome everyone. So Project Bridge is a partnership between the Office of the Ramsey County Sheriff Office and Ramsey County Community Correction. This partnership takes its name from its purpose is to provide a bridge to long-term, appropriate and sustainable housing and increase services for individuals in the county's care and custody. County staff are here today to share information with the board about their innovative program, which began in April of this year. I want to thank you for being here today. And so with that, I want to pass the mic to Deputy County Manager Reyes to begin the conversation.
Thank you, Chair, Commissioners, and County Manager Becker. As Commissioner Moran mentioned, we are here to discuss a partnership between the Ramsey County Sheriff's Office and the Ramsey County Adult Detention Center. As you know, that the Ramsey County Sheriff's Office is part of the Safety and Justice Service Team. And we will be talking about how our correctional facilities do provide long-term, appropriate, and sustainable housing, along with increased services for individuals in the county's care and custody. And we just decided before this was our agenda for today. But if you were able to review that, that's great. We'll go ahead. This is our agenda. And then the next slide, I'll pass it over to Deputy County Manager Abdi.
Thank you, Lisa and Reyes. Chair Moran, Commissioners, County Manager Becker. As you know, my name is Nadir Abdi, the Deputy County Manager for the Health and Wellness Service Team. I'm here today because community correction is part of one of the service areas within the health and wellness. And Project Bridge is the program that allows ADC residents to reside in the RCCF while awaiting for adjudication. DCM Reyes and I are looking, along with the Ramsey County Correctional Facility Superintendent today, Tim Vasquez, Under Sheriff Ashley Bryant from the Adult Detention Center, and Michelle Dina, Correctional Health Manager with Ramsey County Public Health. We'll share the details of this innovative program with you all. As we go through the slides, we will pause to answer any questions you may have. And we'll also leave some room for questions at the end of the presentation as well.
So to talk about this program, we first need to share the difference between the two adult detention and correctional facilities operated by Ramsey County. The Ramsey County Adult Detention Center is a pretrial facility. Pretrial refers to the period between a person's arrest and the resolution of their case, when decisions are made about release conditions, supervision, or detention. The goal of the pretrial process is to ensure court appearance, support public safety, and provide fair, equitable treatment before guilt or innocence is determined. The Ramsey County Correctional Facility, RCCF, is a post-trial facility. Post-trial refers to the period after a court has reached a verdict and imposed a sentence. This slide lays out the primary differences between the two facilities. Pretrial facilities are designed to hold individuals for short-term stays, often lack large physical spaces for programming services and recreation time beyond the minimum requirements. Post-trial facilities are designed to house individuals for long-term stays, often have more physical spaces for more programming, more services, and more recreation. And that is the RCCF. I'll pass it over to DCM.
I have a question. real
Go
quick.
ahead.
Deputy County Manager or DCM and the, so where's the location of the ADC in the correctional facility? Is it the one building that is located on, I can't think of the name.
The RCCF building,
Mhm.
it's located in, Maplewood.
It's Maplewood. Okay, so this one, the ADC is
Located.
In St. Paul.
in St. Paul.
Yeah.
Correct.
When.
I don't know.
425 Grove Street.
Grove Street, and this is in Maplewood, okay.
All right, so Project Bridge, is a collaborative effort between Ramsey County, Correctional Facility and the Adult Detention Center, and Correctional Health. So it's all three areas coming together for that one Ramsey County, resident first initiative that we've been working on. This initiative addresses, overcrowding of the adult detention center while providing opportunities to residents that are awaiting sentencing. Community correction has for many years worked with a more community, less confinement approach, resulting fewer residents of the RCCF. This focus on keeping residents in the community has created a space, the RCCF, to really accommodate people and make sure that we look at things from a different lens. Some of which has been purpose to serve our ADC clients who are anticipated to have longer stays in the facility.
Chair,
Yes. Commissioner Miller?
can we go back one slide?
Mhm.
Okay, so this is, I thank you for this description. I think it really lays it out really clearly and I appreciate that. Is this how we operate though? So do we operate dormitory style up to 1 year? I mean, or is it more, because we know that in residents in our ADC are there for longer than 5 to 7 days. So we know that. So this is, I just want to guess, I want clarification. Is this how we currently operate right now? Or is this just distinguishing the differences in what the ADC and the RCCF are? Am I asking that clearly? Do you understand?
Yeah, so, thank you for that question, Commissioner. So a pretrial is pre-sentence.
Yep, I understand
And
that.
so, oftentimes, residents are there longer because they're waiting trial.
Okay, and then my next question then goes is not all counties have this set up, correct? Ramsey and
Sure.
Washington are probably the only two maybe in the state that have post-trial, pre-trial, otherwise they're just combined in one.
Mhm.
Okay,
And I think on the back of that, but for those who are staying longer than the 5 to 7 days, are you sending them over to the correctional facility?
No.
To stay?
But that's part of the
That's part of
project.
it.
That's part- yeah.
Right, that's
Yeah.
part of the overcome, yeah.
Yeah, great question. That is part of our Project Bridge,
Mhm.
project that we will share with them.
Okay.
So as mentioned, I'm Ashley Bryant, Undersheriff of the Adult Detention Center. So that's the one located in St. Paul. It's the St. Paul Police Department. That is the short-term pretrial facility. I just want to give a little background. Well, actually, first off, I want to just thank you all for allowing this project to even exist. This is it feels very intentional, very deliberate, based on kind of how we've operated in the past. And I just want to thank you all for the support and just the opportunity to have that collaboration. Just a little background as far as licensing all of our secure facilities. So we are, licensed by the Department of Corrections. And for those who don't know, our licensing in the Department of Corrections is based on Rule 2911. And 2911 is a 62-page document that's available to anyone to look at in the statute website. It governs us anywhere from inmate welfare, food service, security, and sanitation. So it's very granular as far as what we're licensed for and what they look at in our inspection reports. The ADC is licensed as a 460 bed facility. 350 is our ideal population that we are looking for. We have been at upwards of 440, 460 this past year. And that is kind of the impetus of Project Bridge, because it was not sustainable of how we were managing the ADC. Our staffing units are in our 24-hour facility, generally means that it's one staff. We say we need 6 for every 1 24-hour facility. That's with relief and kind of vacation, sick, breaks, things like that. Other licensing is dictated on the number of individuals in each unit. So if any unit goes over 60, we would need 2 officers in that unit. And so there's certain staffing ratios we must maintain, otherwise it's a violation of our Department of Corrections license.
Good afternoon, everybody. Likewise, it's a pleasure being here with all of you guys, and thank you for this opportunity. I'm the superintendent of the correctional facility. As you know, the current license capacity at the RCCF is 556 beds. However, the current overall capacity at the RCCF, if fully funded and staffed, is 380 residents. The license remains higher as a part of the county's Continuity of Operations Plan, or COOP, which provides for the movement of ADC clients to the RCCF in the event of a complete evacuation of the facility being needed. Currently, the facility is budgeted to staff a total of 5 housing units at RCCF, which is accommodating approximately at this time 150 to 170 residents. Did I miss a slide? No, I didn't know I was going to be charging. So I'm so good. In 2019, prior to COVID and some of our initiatives, the average daily population at RCCF was 283, with an average length of stay of about 39 days. Currently, the average daily population of our sentenced residents at the RCCF hovers around 95. Year to date, our average length of stay is about 26 days. The reduction of daily census occurred primarily for 2 reasons. First, the Reducing Revocations Challenge. The Reducing Revocations Challenge, or RRC, was a partnership between the Cooney Institute for State and Local Government, the Robina Institute, Ramsey County Community Corrections, the Office of the Ramsey County Attorney, the St. Paul City Attorney, the 2nd Judicial District, community organizations, and community members. The goal of the challenge was to, 1, develop and implement policy to reduce the number of people on probation. 2, decrease conditions for individuals on probation and tailor those conditions to each individual. And 3, develop new guidelines for the use of confinement as a sanction, with an emphasis on minimizing the use and duration of that confinement. As a result of the challenge, Ramsey County has achieved a significant reduction in probation violation rates, executed DOC sentences, and of course, local incarceration rates. The second driver of population reduction at the RCCF was the creation of the Community Alternatives Program, or CAP, which allows residents who pose a low risk to public safety to serve their sentence in the community on electronic home monitoring. We have continued to operate the CAP program, which helps to continue the reduced census at the facility. These initiatives combined reduced the facility population by nearly 45% and allowed the facility to close housing units, convert some of those housing units to increase programming opportunities for our residents, and reduce overall staffing through attrition.
Commissioner?
I have to say that about a year ago, at our last AMC, local, convention or whatever, there was, there was a presentation or a panel presentation on the Reducing Revocations Challenge. It had a number of folks from cross departmental that you had talking about it. At that time, one of the responses was, what would be a challenge in maintaining the strides and the successes that you had going forward past the challenge? And one of the answers was to make sure that those cross-departmental and cross different groups were continuing to meet regularly to continue to evolve and iterate as the program went forward. So a year later, I'm wondering, now that the challenge has passed, have you all still continued to meet with the different parties that made that such a success? Is it an ongoing evolving challenge, or is it something that happened and now you're past it?
It's a good question. We ended up seeing the result of it at the facility, and it was really a probation initiative. I could follow up, or if somebody maybe from probation could answer that.
It'd be great to hear.
Regularly?
Yeah, just because I know the spirit in the room a year ago was, it'd be great if we can keep this going, and I just want to make sure that we don't lose that momentum. Thank you.
I will say that we have continued to see that decrease, right?
Awesome.
What's that?
So how we got here is obviously the adult detention center was seeing very high levels of individuals in custody. And aside from that, unknown lengths of stay. And it's difficult to determine our lengths of stay just because we don't have control over how long they stay. Their stays are dependent on many factors, including court calendars, scheduling, whether they can post bond or bail, availability of bed-to-bed transfers to mental health facilities, and just there's other things that also will keep them in custody, whether it's violations, probation violations, and just extended calendars. That's what prompted Project Bridge, and it has become a very big success for the ADC. We are not designed for long-term stays, and so to have that partnership to give those in custody awaiting their adjudication the ability to have fresh air and recreational programming is just something that was necessary and we owe to our community. And it's those many changes across leadership throughout the county, and the focus on the one Ramsey County that have made this partnership set up for a long-term opportunity, if that is what the county so chooses.
Commissioner Jefferson.
Yeah, I have a couple of questions on the challenges that you're facing at the ADC before we move on to how Project Bridge helped alleviate it. And that's just because a lot of the things that you just described are systemic issues. We're going to talk about the things that we within Ramsey County as a one Ramsey County can do to address those, but some of those are beyond our borders. And I just want to kind of make sure we're highlighting those, because there are, part of our job too is to advocate for changes, capacity building and systems and legislative changes that might make some of these pressures a little easier on you. I guess, and so I just love to hear, is it some of the issues around behavioral health, and substance use disorder, different potential places for people to get the kind of care and treatment that they need. But then also you talked about some delays in the court system. I guess I'd love to hear, and maybe this is for future, to highlight, like, what are some of the things that the sheriff's office and the county attorney's office and Ramsey County has been doing to try to advocate for some of those greater systemic changes, just so we remember, this is what we're doing that we can control, but there are other things we can advocate for.
Absolutely. I know I've sat here before speaking about the Rule 20s, and those are the individuals who are in custody, waiting to determine their competence. There are timelines on that, and 30 days is a minimum for those individuals to be basically assessed and then determine whether they are competent or not competent to stand trial. That has increased over the years, and we are seeing that some individuals are having upwards of, I mean, we've seen individuals with 5 separate Rule 20s, before they are seeing a determination of going to jury trial or things like that. And so those are things that do extend stays that were not kind of anticipated, just because the 30 days is always stuck in their head. Then they will have that assessment, and then they'll continue on about the process. However, I think there's an appeals process. Again, I'm ignorant as far as what that looks like of that process, but we have seen multiple Rule 20s, which again, that extends the stay in our custody. We have, I know the courts has worked towards reducing the number of hearings that individuals have seen. The last meeting I had, they had said that on average, some individuals have around 10 hearings before they actually see a jury trial or their trial judge. And I think they're trying to expedite that and have initial again, conferences to reduce the number of hearings before they're actually adjudicated with what they're charged with. So we are seeing different individuals work towards reducing the backlog. And I don't know if it is a backlog more so than just the process of the judicial system. And it's just not enough based on what we're also seeing out in the community as far as individuals being arrested for violent crimes. That they are deemed a public safety threat and they must remain in our custody. Generally, the individuals who are not the misdemeanors, I guess, would, for individuals just trying to understand, most misdemeanors do not stay in our facility. It is very rare, maybe through a weekend, that they would stay or fail to appear where the judge needs to see them before they come. The individuals in our custody are generally there for very serious crimes, or they're awaiting the Rule 20 mental health evaluations.
So when you say that, so the bulk of folks who are here quickly, you know, for under a week, as the center has been designed for, are the lower level cases. And the ones who are sticking around are either higher safety concerns and or they have a Rule 20 or other reason why they aren't being released back into community while they're waiting for their trial.
Absolutely.
The question I have for you then is, given that, you know, what percentage, if you looked at your census, is driving the overall stay rate? Is it that you have maybe 50 people who are there for months on end and everybody else is kind of cycling through as is planned? Or do you have a creep of, because of the trials process, what would have been 5 to 7 days is typically more like 3 or 4 weeks? And also, if you're of this other case, you're there for months waiting for a commitment hearing. I mean, I mean, it's not just the numbers of people coming through, but what's keeping them there longer?
Correct. I would say, and I would have to really do a deep dive as far as the data goes, but I would say of, you know, the 400 that were in custody, I would say 150 are the very, very serious ones where there is a process that must be followed in order for.
So that'd be like a third of your residents.
Absolutely. And that might be minimizing the number, just because the individuals in custody are usually very serious, or they have multiple charges. And that's another thing, that they have to go through our process and then go to a Hennepin County or Washington County. And so they can't necessarily bail out until they're done with Ramsey County, because then they'll go to the next county. They have a hold.
I have one last question on this. And the reason why I asked all those questions is then that the population of folks who are driving the additional stays are a very specific population. So even, you know, for every day that they're there, is there additional type of staffing, services, medical or mental health care that these individuals need more than a typical resident who is in and out in a short period of time? And because that also is driving your staffing needs and the other specialty care of the other departments that are supporting the ADC.
Absolutely. I always liken the ADC to the hospital of incarceration, because, or the ER of incarceration, because the individuals come in, they are decompensated, they're going through a crisis, they have chemical health issues, mental health issues, and it is our correctional health staff and our mental health staff that are able to stabilize them to perceive what is going on. And that takes time. Somebody might need an entire month to regulate. And that is also part of the Rule 20 process because they don't want to do that too soon because somebody may need to be regulated on medication before they can also understand the process. So there are little minutiaes that why the process is how it is and not necessarily that it's broken. It just makes more sense to wait if somebody is not on medication at that particular time.
Thank you for that lengthy thing. I just wanted to set the stage because I know this is part of a bigger process.
County manager.
I say, Commissioner Jefferson, I appreciate the line of questioning here. I think one thing I will ask, maybe you, Ashley, and Deputy County Manager Reyes to work on is to give us sort of this operational rhythm of the ADC. I think for us to understand the best custody and care facility needs that we have in our community, understanding that flow of exactly what she's asking, how many people are staying long, and even like the conversations we've had with the sheriff about maybe increasing booking fees before I take that out to the cities and see if it's worth the juice is worth the squeeze. If that's not really the operational rhythm, that's really a lot of people. It might not be worth, you know what I mean? Like, I just need to understand the flow of people and how long they're staying and in general over like the last 5 years, post-COVID, maybe might be a really good marker. So maybe we can work on that, Commissioner. Does that sound reasonable?
Yeah,
Okay.
I think that sounds great because the whole idea is I'm excited to hear about this particular project bridge, but I also know we're just getting started on making this right for everybody. So thrilled. Yeah.
Commissioner Jones.
You had referenced the rule of 20, and that's something that I've heard tossed around here before too. Is that what contributes to the timing or the length of stay? Is that a big factor? And what would you say is the biggest barrier? Like, why does it take so long to get a rule of 20 evaluation done?
It is, because in order to basically when a Rule 20 is ordered, the criminal is paused. And so they need to determine whether an individual is competent or not competent to stand trial. And so the evaluation for that Rule 20 needs to be done within 30 days.
Yeah.
However, if they did it on day 3 and they're under the influence of something that came in with, or they're just completely decompensated, it does them really no good at that point in time. So we do have to wait for a little pause to actually do the Rule 20 analysis. And then it takes time to write the report and for it to come back. And so during that time, they're sitting and waiting. Unless we can get them to a treatment provider out in the community, then there are times where we can get them CR'd, conditionally released to a treatment provider or a different bed space.
For the evaluation, do we do it in-house or is this contracted out? Or does it have to be contracted out, I guess?
That's a good question. I think it's contracted out, but I do not know that.
I believe it's contracted out as well. Usually Radius does them.
I would have a question about like capacity, it's like, do we need more providers? Yeah.
I was gonna say that too. Is it fair to say that the number of those who are coming in struggling with mental health substance use is just continue to grow, where the capacity to get them in timely too, it's not happening within that 30-day period?
I think they are being completed within that 30-day
Okay,
period. It's just, we have to wait the 30 days. And so that's 30 days in a facility that is meant for 5 to 7 days. That feels longer than it should be, or is longer than it should be. And so, okay, go ahead.
Go ahead.
While the goal of Project Bridge is to address the overcrowding at the ADC, which we have stated, you all know that the creation of this program was more than just the bed usage at the facilities. This program in partnership represented a concerted effort on behalf of both facilities to provide supports for our incarcerated community members. Because the RCCF is structured to house longer-term residents, the facility can offer programming and services with a focus on habilitation to help those residents be better prepared for reentry to community. and remain law abiding. The extent of this type of programming is simply not feasible in a facility designed for short-term pre-sentence clients. I was going to go through some of the opportunities that we offer for all of our residents at RCCF, and this includes the Project Bridge residents. No-cost phone calls and video visitation for family and friends, access to caseworkers who assist our residents with a variety of issues that they face, from the court assessments and pending court dates to facility programs and services, either through their caseworker or by self-enrolling through their kiosk located in their units. Residents can enroll in a variety of programming at the RCCF, including our Learning Center. The programs there include the GED testing, high school diplomas, ESL courses, and most recently, formal certifications in Microsoft Office. The Learning Center is also tied to the North St. Paul Maplewood Oakfield School District. This allows us to also coordinate post-release educational services for our residents that are transitioning back to our community. Residents through the Transition Services Unit, such as they may receive services such as information on peer support case management through People's Inc., Radius Health, and Wilder, information on and assistance with post-secondary educational services through TRIO and the Dakota Institute, and peer support education services and housing support through JAMA Place. Residents can participate in religious services like Bible study and Friday prayer through the Islamic Resource Group. They can attend cultural programs, and events held by RCCF in collaboration with our community members and the receipt team. All programs and services are discussed with our caseworkers or through meetings with our transition services and health educators. There are a number of other programs related to religion, culture, community, and cognitive behavioral therapy are possible. Both sentenced and pre-sentence residents may request to, and be assigned jobs within the facility, such as facility cleaning, kitchen duties, and laundry services. In January 2024, RCCF began incentivizing the work and programs offered at the facility. Through this program, residents can earn upwards of $25 per week if attending work or school, and in addition to any programming that we offer. This pay was determined to be on par with that of neighboring counties who offer the same incentive, as well as the DOC. The paid residents receive daily is then used to purchase extra commissary that we offer, and or residents can save their earnings so they have something to take home as they return to community. All residents receive incentive pay for these jobs as well as any programming they participate while at the facility. This slide here, this breaks down the programming that to date the Project Bridge residents have taken advantage of. You can see a total of 77% of residents of Project Bridge residents are ADC clients. 77% have taken advantage of some type of programming that we offer at the facility. And I invite Michelle Dean to speak about the correctional health offerings.
Oh, yeah. Thank you. Thank you, County Manager and Commissioners, for having us today. I'm Michelle Dean. I manage the Correctional Health Services for St. Paul Ramsey County Public Health. Correctional Health provides medical staffing and services for all of Ramsey County's correctional facilities, including the RCCF, the ADC, and the JDC. The residents that are coming from the ADC, from the street, often have very acute needs and high level needs. They require focus on triaging to address the immediate health needs. As a medium security facility, the physical space and movement of patients at the RCCF allows for more intensive attention to healthcare needs and allows us to focus on their chronic conditions, prevention, and discharge planning. This allows for us to deliver a higher quality of care that is more focused holistically. There are many ways correctional health supports Project Bridge. Go through a couple of them here. We've added 2 correctional health staff to ensure that all residents have access to correctional health services over at the RCCF, including we provide them medical clearance, leaving the ADC to the RCCF. So we'll kind of go through their charts and make sure that they're good to come over. We identify patients that can benefit from the programs offered at the RCCF. Staff provide medical care to address both the chronic and acute care needs of residents at both facilities. And staff complete medical intakes and health assessments for all residents to help understand the current medical conditions, the medical history, and the medical needs for all of the residents. We offer medication-assisted therapy to residents, including daily Suboxone clinics for those with opioid dependency and withdrawal. The Suboxone clinics are available both at the ADC and the RCCF. The ADC oh, go ahead.
Can you talk about the outcomes or of the Suboxone clinic in relationship to for those who are there, but when they are released back into the community? Are you finding it to be successful? Are you tracking them and following them?
Yeah. I talk about that in just a little bit about what we want to do with Suboxone so that we can make people more successful when they leave. Yep, I'll get right to that. The ADC residents that participate in the clinics, they're housed together over at the ADC, the opioid use disorder people that are on Suboxone. And we're better able to identify them then, and who could maybe benefit from therapy also that's offered over at the RCCF, because they have group therapy and individual therapy for people with substance use disorders and opioid use disorder. So we identify them and then we try and get them into that Project Bridge program to better treat them over at the RCCF with not just medication, but that holistic approach of therapy as well. We pay for this medication through multiple sources. We have a SAMHSA grant in conjunction with our clinical services department, the ORIC grant in conjunction with our clinical services department, and then opioid settlement funds and levy funding as well. We are soon hoping to use Sublocade for opioid use disorder. This is a long-acting injectable medication. We're going to be paying for that with our opioid settlement dollars. And doing a pilot program at the RCCF first. This long-acting injectable medication would be in place of daily oral medication. The medication lasts in the patient system for 30 days, allowing patients to be able to release to community with medication coverage and stabilize challenges that they face during re-entry without the need for oral daily medication. Because we know that that medication coupled with therapy increases successful treatment outcomes for those with opioid use disorder, the nurses at the ADC identify the residents participating in that program or who have been on that protocol as priority for Project Bridge. While MAT is still available at both facilities, we're better able to do discharge planning at the RCCF for these people. And because they're in treatment, they're getting, with the group therapy and the individual therapy, they're getting identified for treatment resources out in the community that way as well.
This is
oh, go ahead.
I just have a quick question too, as you were explaining about what we're able to provide over at our correctional facility.
Yeah.
When the DOC did the evaluation of our ADC, was this group included a part of that evaluation from the Department of Corrections?
It was not, because they look at our facility and the individuals in custody within our facility. So
Okay.
the RCCF has their own that they would look at.
Okay. Yeah, I would like to get an update or a report on that if we get evaluated on that as well too, since this project has taken place.
Just to follow up on that though, you have both of those, you have the Suboxone clinic in both locations, and then so that there would have been people who would have been on this protocol in both locations during your review, correct?
So the DOC doesn't have an oversight on the Suboxone. They look at more the minutia of how medical does their practices and the processes. So there is nothing in there, I believe, that they would look at how
exclusively, but they would still be seeing, this would be part of a medical management that they would have been reviewing along with any other meds or not, or it's not really?
Not really.
Okay.
It's more of a technical technical of how our process works, if that makes
The
sense.
operations.
Yeah.
Yeah, more operations, they don't drill down to a specific medication or a specific disorder or a population of people, if that makes sense.
Mhm.
So,
Good question.
yeah, math available at both facilities. We feel like having people on this injectable medication and doing this pilot program will increase the amount of people that go to a community clinic provider and continue their medication needs. We have been finding through our grant studies that it is really difficult to find that population once they leave our facility and find out if they have successfully transitioned to a community program. The best numbers we really have are the ones that come back into the facility and we know that they used in the community and they weren't successful. We don't have great numbers following up with people after they leave the facility.
So would that mean right now you don't have like a partnership with a community-based organization that they can transition to?
We have several.
You have some?
Kai Shing Clinic is one of them that they transition to. That's an outpatient clinic. And then a lot of times they'll, be referred over to M Health Fairview for services because they have pretty in-depth services for Suboxone.
Is it a way that you can track that or ask for those numbers?
Yeah.
Since you know,
Well, once they release, they'd have to sign a release of information for us to get that information back, and many times they just don't. So it's difficult.
is it a way to do that without asking for personal information?
I mean, we could look closely at it. We did try to do that with M Health Fairview and Kaishin through our grants and weren't seeing good numbers coming back. Even though we made people appointments before they left the facility, they knew when their appointments were. It sounded like people just weren't keeping up with their treatment out there. So. We review quarterly the patients served in Project Bridge, and we're trying to work together to prioritize patients who could benefit from this more holistic treatment approach that we can offer at the RCCF. We also have dental services in both of our facilities, but due to the amount of people at the ADC, it's easier to get people into dental services at the RCCF just because of the number of patients at both facilities needing care. Appointments with licensed drug and alcohol counselors in the facility are also readily available to residents. And residents at the RCCF have access to daily programming with those chemical health educators that they have over at the RCCF. Finally, we also provide discharge planning, where we order medications, provide health education prior to discharge, and connect people with providers and appointments for medical and mental health needs following discharge.
So I feel uneasy here, so
Okay.
I'm gonna go back a little bit to my question about being able to follow and track. Because I think, if we got one or two successes, I may not need it to be in abundance, but if there's some way that we can go back and see that, we, for 30 days or 60 days or 9 days when they was here, they was in a good program. When they transitioned out, they went to wherever they went, Fairview or whatever.
Yeah.
And maybe they stayed for 3 days or 3 weeks or 3 months. But some type of visuals that can help us tell a story about what's happening.
Yeah, and some people are sentenced to go to inpatient treatment, right? The majority of our patients go and we refer them for outpatient treatment. And I think probation would have better numbers because they're sentenced to inpatient treatment and what that looks like and how long they stayed and if it was successful. But the outpatient treatment, that's where we really struggle. And I think you're right, we could come up with a better way to find out who successfully did outpatient services and were they successful at it.
Even we had to partner with probation.
Yeah.
To try to get those numbers.
Yeah.
Yeah, thank you for sure. I was just gonna say, I think I really appreciate, the distinction between the different facilities and like the work that's being done because the spaces are different and people have to move around differently. And there's different, spaces to be able to do certain services. I hope that through this project, we can think a little bit differently and stretch ourselves into like more of a gray area where if we see best practices of something we can provide that you've learned in Project Bridge that, okay, in RCCF, it could work this way. We don't have to necessarily say, well, we have to have the ADC set up a certain way to provide something slightly better than what we're doing today, right? Because I mean, at the end of the day, we're not getting new facilities anytime soon, right? We have to live with the facilities we have, but trying to think about how we use them differently and think about how we at least can attempt to try to give the best care with the facilities we have. I think is kind of something we have to push ourselves on over time. And I'm hoping by just even this project, in a way, there's some experimental thinking around, oh, yeah, like we can do it in a smaller space, or maybe we can do it in this way, right? Just to even improve a little bit of the quality of the care that has been somewhat hamstrung at ADC because, you know, it isn't set up for it. You know, I know we keep saying it's not set up for it, but at the end of the day, we're never gonna have a facility that's set up for the population we're having these days. And so how do we sort of continue to push ourselves? So that's just a thought for you, Michelle, as you think with your team in the future. Of, you know, maybe we're not gonna be able to invest money to redo the ADC, but like, is there some amount of resources that could ensure some better quality of using the space we have?
Right.
I don't want the space to be the only limiting factor, I guess.
No,
if
and I
that makes
think
sense.
it's staffing too.
Okay.
You know, the correctional facility provides us those counselors, right? The individual counseling, the LADCs and the group counseling. At the ADC, it's just not been a facility where that's been offered in the past, you know, so we utilize the resources from the correctional facility too for those patients.
Yeah, I really like that very first slide you guys did, even though I appreciate the commissioner's question of like, between the two facilities, what is kind of the goal of the building versus like what is the as is? But I think a lot of this presentation could be put into that context of the multiple spaces, so we can better understand how those spaces are being used and how the staff are being used differently in different spaces, right? Like if you were gonna more mirror some of those things that you're talking about in the RCCF over in ADC, like what would that have to look like? Well, what's missing there? What are the missing gaps? Is it only a space thing? Is it a staffing thing? Is it a community partner thing? Is it a, like today, Ashley talked at the board meeting about they got iPads and different learning things. Now they're doing free calls. Like there's a comparison and sort of an analysis that I don't think we're quite getting to the granular level that we need to be, I think that would help decision makers as we think about resourcing in the future. And with things the commissioners,
Sure. Well, like, it's to that point, to add to that would also be, I think this is what you're getting at as well, is to say, this is what this is designed for and how we're providing, but this is the population that we're serving within these different spaces. And not only can we be thinking about how do we move people from the ADC to the correctional facility that has more broad programming, but how can we recognize the population that's in the ADC? And while this is not ideal or the end solution or alternative to advocating for greater capacity within the outside system, but while we are doing those things, these folks are in our care. How do we set up that space to meet the need of the population? Not that it was designed for, but that we are truly serving. And to kind of come up with that, to say, if this is a population, regardless of which building or which facility they're in, what would be the way to meet those needs and to properly set them up for success when they do leave our care, which most of them will very quickly, and back into community. Like, how do we end that? I thank you, County Manager, for setting that thought process up.
Madam Chair, I have a question similar to this too, about how does the funding work here? With Project Bridge. Does that mean that the costs are absorbed by the corrections department?
Yeah, so in the 26-27 budget, we put additional funds into community corrections without property tax levy to continue the Project Bridge effort.
But what about for this year then? Because
this year correct me if I'm wrong, but corrections had funds that they were utilizing from their budget to do the project this year. It's kind of some bridge funding for Project Bridge.
Okay.
Yeah.
I mean, I guess I'd like to better understand the staffing model too then, right? Because our correctional facility is 24 hours as well too. So just as some kind of comparison in terms of like how these facilities are managed with like staffing levels. And what that would mean, right? Because we just did an RBA, right, where it was, 4 million for, those overtime costs. And then we haven't seen that, overtime request from corrections too. So that's what I'm just trying to figure out, like, what is the staffing model that, fits in our broader conversations moving forward together?
Okay.
All right, and mental health is not with us today, so I'll talk about that too. We also offer, mental health services, somewhat, we do a lot of assessments and things like that. RCCF, also has staff for mental health services. And then, social services provides the mental health services at the ADC. And then we have contracted, service providers, through social services that provide the psychiatry care. Mental health services are available to all the residents, either by request or referral from their caseworker, correctional health staff, or corrections officers. Residents have access to psychiatric care arranged by social services in the correctional health clinic 2 days a week. RCCF staff provide chemical dependency assessment services. That's correctional health staff over there, or corrections staff over there. And then residents can receive mental health care from licensed on-site RCCF staff.
What population or what percentage of your population in both the ADC and the correctional facility do you believe are taking advantage of or would necessitate behavioral health, mental health, substance use disorder services? Is it a small percentage? Is it a large percentage?
It's large. I track a lot of the medication because we still provide the medication for the people with mental health. So of the psychotropic medication, 58% of the population of people are on some kind of psychotropic medication. So they would be seen by 58%.
In the correctional facility?
Yeah. Yeah.
And the ADC?
The ADC, it's close. It's like 52% are on some kind of psychotropic medication.
And these are the folks who have gotten the diagnosis and treatment and care to know they should be on something, not folks who are waiting to get those proper assessments and perhaps have access to the healthcare that they would need to be able to.
Correct, yeah. Yeah, a lot of people with mental health needs in both of the facilities.
We could get that percentage for you too, I know, because I'm talking with Kyle Norton, who's our mental health supervisor at RCCF. I know it's Krista at the ADC. That's not even counting the number of referrals, and I honestly, it was 70%, if not more, are mental health referred, which means that they have met with a mental health worker while at the facility, or are meeting with them regularly.
And Krista gives me numbers per month for referrals. She gets about 300 a month at the ADC. It's a lot of referrals.
And the other piece to this is the idea of individuals who are in our care lose their coverage when they're in our care. So then we are absorbing those costs as a county, correct?
Correct. And more people are on injectable psychotropic medications, which are very expensive. So coming into the facilities to bridge their care, a lot of times they request that, we keep them on the psychotropic medications, they being the case managers in the community for their mental health needs, especially if people are committed, civilly committed. They request that we keep them on those psychotropic injectable medications, but they're very expensive. And there's just been a boom of them in recent years. And they're between $1,000 and $3,000 a month per medication.
And correct me if I'm guessing the name of this wrong, please do, because I just enough information gets in trouble. Is this the Jarvis?
Jarvis.
Yeah. And
Civilly committed with an order to force medication if necessary.
Well, and then also, is it Travis? There's another that basically is keep, there's a legislation that's saying that you have to keep on the same meds that somebody comes in with. You can't generic it or make it just like an easier to dispense. It has to be what they themselves came in with.
The Larry Hill legislation.
Thank you. I was, yeah, there's a lot of names attached to these. But so that there are lots of things that are regulating how and when these things have to be done.
Correct.
And that's driving costs.
It is.
And so, and again, I want people to have the care that they need.
Yeah.
And also, we have to find a way to pay for it.
Right. Yeah.
Can you share with me what medication assisted therapy is?
Medication assisted therapy means that you're taking a medication to either withdraw from a substance use disorder or to maintain like a maintenance drug so that you don't want to use substances. And that could be for alcohol use disorder, opioid use disorder, many different disorders, but you're utilizing medication as an assistance in therapy.
So I'm just looking at when you have 72% of the residents who are dealing with mental health, high population coming in with substance use disorder, but only 11% is of the Project Grid residents receive the medication assisted therapy.
Yeah.
Why is that?
So
Why is that
some
number so?
people use the medication for a short period of time for withdrawal, and they don't want to be on it for maintenance, which is fine. It's up to them. But a lot of people will do that and get through
Why is it
that
up to
withdrawal
them
process.
when you know they're struggling and that causes other
Well,
issues?
Yeah, they can refuse medication. So we can say, you know, we recommend you be on it. We'll continue the order, but if they don't want the medication, you don't need to take it. You know, they can refuse it.
That's okay, okay.
Mhm. And the oral Suboxone is really inexpensive. So we like to keep people on it. It's about 80 cents a day for
Really?
somebody to stay on that medication, the oral form. It's very cheap. So we like people to stay on it, especially if they've had opioid use disorder. It also works well for people with alcohol use disorder to cut cravings.
Because those are the other issues that comes out of folks who are not getting treatment. You know, is that a legislative thing? Language where they don't have to take the medication or
Well,
a decision within the institution?
yeah, the only way that they could be made to, for that kind of medication is if they were civilly committed for chemical dependency and the judge ordered it.
Okay.
Yeah.
Go ahead.
Yeah. And then, let's see, residents can receive mental health care from licensed on-site staff at RCCF. And then the facility mental health staff continue to support residents following release by collaborating with field probation to stay in contact with residents who serve probation following release. So a lot of those people stay in contact through their probation officer, and we know what happened to them. We do take some of the Rural 20 population of people that we've talked about before over at the RCCF and work with social services, Krista Delgado at the ADC for placement of those people if they're at RCCF as a boarder.
And can I just say, at a recent tour, we learned more about the outside in and inside out, contracted providers, community providers that were helping with some of these transition services. Am I grasping that right? Was that part of behavioral mental health as well? So that some of the services that folks were, some of the maybe counseling and other kind of services that people were getting at the correctional facility would be with an organization that then they could continue with that care when they're back in community, because the same workers may be back and forth, the same organization may serve internally, so that when they go out in community, they can still continue with that care with somebody they've built a trust and rapport with.
I think there's some of that at RCCF right now. The psychiatric providers are contracted through a staffing agency and no, do not see people in the community. I know that. And that's through social services. They contract with those providers. Okay.
And the mental health team does try to connect the residents with resources outside, and they do, Michelle kind of stated this, but they are in the field probation offices, meeting with residents So after they've left the facility, it's that continuity of care. And down to, they go to UGM, certain days of the week. So there is some of that. I don't think as much as obviously is needed, but there is some of that continuation of care for that as they leave the facility.
I just wanna, I think what you're, I think it was the education piece that they connect with community. Outside of once they're released from RCCF, wasn't it? Is that, am I correct in that?
To the
Tim?
learning center?
Yeah, the learning centers that they can still continue their program that they're on.
Yep, and with
Outside.
the independent school district.
Yes.
correct. Mhm.
Okay, maybe that's where,
Yeah, I think it's both and, but
Yeah.
if not, then it's something I think that is something to consider. I believe there is some of that, but the idea, and I'd be curious to see how much of that is helpful too. Again, once somebody has created that trust, that's half the battle to them, not just not wanting to take that piece of paper once they're out in the world.
Yeah.
Right.
All right, now I'll turn it over to, I think it was Tim. Oh, back to Ashley and Tim, yep.
So we're just gonna talk about how we identify participants for Project Bridge. As stated before, our CCF is a medium security facility, so some individuals are not eligible. I think we spoke before how we have a G unit, which is a unit that has individuals who are very well behaved and they get extended privileges, and there also they're all 60 individuals are out at the same time. And many of those individuals are not eligible to go over to RCCF, even though they would likely thrive over there because we know that their behavior is good enough to go over. When it comes to identifying participants, we do try to look at their court dates, more extended court dates that are out, where they would be more long-term to stay over there. As Michelle mentioned, we do have them cleared by medical first before they are going over there. Right now, or in the beginning of this program, just because we were so over our capacity, we were just sending over anybody that we could identify as willing. Generally, there is no criteria except you're well behaved and your charge level fits well enough to go over to our CCF. If there are any individuals with poor behavior, they do come back to us, and we just like to maintain that relationship. In the future, if there is a more streamlined process and if we're not just in crisis mode all the time at the ADC, having a set criteria would likely be the next step into a kind of expanding Project Bridge to give a more cohesive answer to who is going.
I really like this language using maintain relationships, residents. Commissioner McMurtry.
Thank you, Madam Chair. You mentioned that at the beginning that you were just, I guess there wasn't a set criteria of who was going over. So did you have examples of residents from the ADC who went over to the correctional facility who may have had more challenges with their behavior, that because they were in this new space with folks who behaviors were, more to where, we are expecting folks that they saw a shift in how their behaviors were because they were interacting or learning from those who had better behavior?
Great question. We would not send the individuals with poor behavior. They wouldn't even be considered to go over there for that.
Even at the beginning?
Even at the beginning.
Okay.
We had enough who were, and that is kind of, when we talk about kind of the challenges of this, is the ones who are well behaved are kind of dispersed amongst the entire ADC population. Because all of our individuals who are going over there, it slowly gets down to now we have very poor behaviors and there's nobody in our certain housing units to model that good behavior. So some of our housing units have become so much of an issue, we have had to staff them with two individuals, or two officers. That has always been my priority anyways, to have two officers within it. But this is a need now, not a want, to have two officers within housing units. Now, when it comes to, again, the G unit, that one does not need two officers within it because they maintain and they police each other, which is great.
Do you still have the G unit open? It's just with new inmates now.
Well, the individuals in the G unit are the ones that have very, very serious charges, and so
They can't go to
they
RC.
can't go to
Okay.
RCCF, even though, again, they would thrive over at RCCF. And so that is, you feel bad
Right.
because these individuals have proven themselves time and time again that they can abide by the rules and we can't send them over there. So we do, I don't want to make it sound like the ADC is just this horrible environment. We do, as County Manager Becker stated, we have the space, and the space is what is limiting us on what we can do. And what we are finding is technology is where we are going with to figure out how to utilize our space more appropriately. That's with the tablets. Before I came here, I did run, so we've only had the tablets for 2 weeks, and there's been 11,729 programs that have been completed by those. And so, yeah, it's great. One individual had 201 programs that they completed. So they're looking at that stuff. And then just out of my own curiosity, because I do love data, what were the top programs that they used? It was health, working out, nutrition, and finance, were the big ones, which again, out in the community, that's exactly what we should be focusing on, because if you get that in place, then a lot of times you don't need to be in ADC because you have great direction.
Right.
On the counter to that, have you had anybody who has been selected to go to the correctional facility and failed to succeed and had to go back to the ADC?
Absolutely.
Okay, so there's a protocol in place to balance out.
Typically, it is a struggle to find that balance, right? To find that balance because you want somebody out at the facility that's going to take advantage of the programs and services that we have. We don't want that to be taken away because that person's been such a behavioral issue that they're insecurity or they're locked down in their unit because they can't participate. I don't think it's fair to the other individuals that are coming there to take advantage of those services. That said, I mean, I think we're always trying. I would say that we are always the facility of second, third, fourth chances. And so when we do have an ADC resident that is coming over that is challenging, it's not an immediate send back. And when we do send them back, it's with the resident notebook entries that the officers have made, typically 2 or 3 incident reports. And so we're having those conversations with those ADC residents saying, listen, we don't want to send you back. I mean, we want you to take advantage of this stuff. So please, come back out, go back into the unit and begin to start to take advantage of the services that we're offering here. And if it doesn't work out and they don't, then we do send them back. And then when we send them back, it is with the notebook entries and the incident reports so that, again, in collaboration with the ADC, so they know that we're not just sending anybody back, right?
Okay, let's move on.
All of this wouldn't be possible without Assistant Superintendent Eugene Warner. She and over at the RCCF, Captain Michelle Landers, Assistant Superintendent Warner goes through each new admission, each individual every single day to see who would be eligible to go over there. And that it is painstaking work to be able to look at all the classification, all the behavioral issues, and just determine, and the charges, determine who is eligible to go over. And then it goes to the medical, can we send these over? Then it goes to transports, can you bring these individuals over? And we look at court dates as well. And so it is right now it's a very well-oiled machine of how we're sending individuals over, and it's working, which is great. This all started in April of this year. It initially started with 30 male residents and 10 female residents moving over to RCCF. In June, the 30 male residents were moved over. And then in the end of August, they opened up another unit, which again allowed us to take or send another 30 over. So right now, there's between 60 and 70 at some point in time over there. I think it's at 63 right now. And then they did agree to take an additional time. Right now, as I tell people, our ADC is like kind of chaos because we're doing suicide barriers. So a housing unit is shut down and then they're replacing all of our elevators as well. So we're having visitors being escorted in and out of facilities just because it's a different process. And so they're graciously taking an additional 10 until we have the housing unit opened back up again. Okay.
We did have some data that we were able to pull. I mean, granted, it's from April of this year, but we wanted to break down some of the statistics for you and go over them in these next few slides. This is the total number of admissions and releases by month. As stated previously, the length of stay for these participants is based on a number of criteria. Although we attempt to find longer term residents, we're not able always to do so. And just to be clear too, when an ADC resident is scheduled for court, the resident is temporarily released from our system at RCCF, and then pending the results of that hearing, residents are then released either from the ADC or returned to the RCCF until another hearing is scheduled. This next slide is the average daily population at the ADC since RCCF took the first Project Bridge residents on April 10th. The top of the bar in orange are the Project Bridge residents. The lower bar in blue is the population that is remaining at the ADC.
What's the ADC capacity?
What was it, 400?
460. Okay.
The next slide here is the RCCF. So this indicates the average daily population at the RCCF since housing the Project Bridge residents. At the top of the bar in orange are the Project Bridge residents. The lower bar in blue is our co-sentenced population.
Can I ask just,
Commissioner Miller?
I just want to confirm the capacity at the RCCF is 557, and you said at fully funded, or what's it funded at now? So capacity, was it 157?
Right now we have 5 housing units open,
Okay.
and we have a total of 150 to 170 residents. If fully staffed and all of our units are open as they are, it's 380.
380,
Yeah.
okay. Where I got 550, that's a lot.
The license capacity of
licensing.
556, and that's we keep that number because of the continuity of operations.
Okay,
So in the event that the ADC would need to do a full evacuation, we'd rather
you'd be, okay,
contact. Yeah.
okay.
So this slide indicates the average length of stay at the RCCF by month for our Project Bridge residents. See, most of the residents stay for a period of 3 to 5 weeks. April, of course, being a little lower because that is when the middle of April is when we first started receiving the Project Bridge residents. This next slide here indicates the population demographics for our Project Bridge residents. And just to reiterate that this breakdown represents the residents who are being sent to the RCCF from the ADC to take advantage of our services and programs.
Is there a great similarity or disparity between the demographics of the folks chosen to take advantage of the bridge program versus the general ADC population?
I would have to go in depth on that, but I would say it's pretty comparable to what we see at the ADC.
What I would like to see is you have the number of residents who are Project Bridge residents, right, by race. I would like to also know by race who is getting the opportunities versus by age. Right, so for this year, Project Bridge residents by age. Women, and not women,
And then on the other side,
by race.
the age.
No, okay. What's your
Quick question, for these numbers here, is it just for males? Do we have the numbers for,
Yeah, 77.
but the breakdown?
Oh,
Oh, broken down, that's a good question. We could get that to you.
Okay.
Thank you.
And this is something in the future we might be able to be intentional on as far as a ratio or something like that, but we do not go through and say, oh, we haven't sent an Asian individual over to the RCCF. We're looking at charges and behavior right now.
I mean, it's Chair.
Commissioner McMillan?
Could we see maybe the data of the demographics like this, but for the total RCCF facility? Not for Project Bridge, but just out of curiosity in our court system and how that breaks down at.
Yep.
Who's sent to prison, who's sent to under a year, and who's sent to probation, would be just good to see.
And then this last slide is the offense levels. And this indicates the most serious offense level. So we do have some of the residents that are there on multiple charges, but so we took the most serious offense level of those. And as you can see, the most of participants that come out from the ADC are charged with felonies.
Well, that makes sense.
Right.
They're longer through the court system than maybe a misdemeanor or gross. So, yeah.
So what next? And we call this Project Bridge 2.0. So the facility is continuing to expand services to residents by working together with even more Ramsey County departments. They include working with housing stability, social services, workforce solutions to provide the residents with more tools and opportunities as they transition out of our facility. Following our best practices models, we're constantly looking to expand programs and services focused on habilitation and through partnerships with our community. Correctional Health is finalizing accreditation through the NCCHC. We're looking for ways to expand the resident incentive program opportunities, looking to prioritize educational milestones and certifications that our residents can take with them. And expanding our cognitive behavioral therapy through our transformative services, adapting our CBT programming to offer a COG 101 services so that shorter term residents are able to take advantage of this.
Madam Chair, you know, for the goal, I would actually, suggest that, it's like laid out or spelled out, more so about what our goal is working together. That way there's just like a clear, vision of, everyone who's at the table working together about, right? Like so that when there are decision points, it's like, are you going towards that goal? Like, does that help meet your goals, right? Because I would actually like to see, some of our goals, if maybe in our future conversations about like decreasing, like let's work towards decreasing the time that people are in our care. Like how can we make them out as quick as possible? And then I think I would just suggest having like some like metrics, metrics around, just care or quality that they're receiving, feedback that we get from folks too and families.
Yeah, right.
Okay.
So I just want to highlight that, all this work that has been done is showing what this one Ramsey County idea and philosophy can do. The way ADC has always been, it's been a silo. Still being, fairly new, as the under sheriff of detention of the ADC. I don't know everything that's out there that the community provides, and I think that is the huge disconnect is there's individuals or programs that can help the populations in the ADC, and I just don't know that they exist to bring them in. And so I would like to see at some point maybe a decision tree or a workflow of what it looks like. This person meets this criteria, and then we contact this individual, because that communication is very easy. It's just knowing where to look when an individual needs resources.
I would like to see that as a goal.
Yeah, absolutely.
And those laptop or the tablets, you know, could create even a self-facilitated, you know, piece to a lot of those resources, right? At least a first start, right?
Yes, absolutely. After COVID, nobody wanted to come back and volunteer into the ADC. Now that we have tablets, we can, I know we've talked about telehealth in the future, but any of these resources in the communities that are willing to help individuals in custody. And it's not just the ones that stay. I feel like we do a disservice to even just a simple DWI. They might have a chemical dependency issue and they just got caught this time, but it's not addressed. And so to grab that individual before things escalate and they become a long-term resident of the ADC is where I think we're missing our mark, because we're just letting them out the door and we're done, you know, and we let them figure out the next step. And I think for us to be able to provide them resources as they go out the door, or a prompting of, hey, why don't you try this? Or even I would like a soft kind of handoff into the community from the ADC, and we don't have that right now. Those are just the Project Bridge 2.0 that I would like to see.
Sure.
Richard.
As you go through this list of challenges, it kind of goes back to Commissioner Jevon Singh's previous point of identifying those challenges that are within our purview of that we can tackle versus those that are more systemic, that may take a lot longer. So I would love to see like some type of a plan to, as we look at these challenges, to also identify okay, here are some of the steps that we're taking. Are there certain coalitions that we want to join to kind of help address some of the more systemic issues that we're dealing with? Just to be a little bit more strategic on how we can get towards some of these bigger issues, because they're going to continue to exist and they're going to continue to cause strain on our systems. And what is the plan to ensure we're chipping away and ensuring that we're trying to address some of those larger issues on top of course, what we can directly do as an organization, but looking at that bigger picture as well.
Absolutely.
And I think one of the things that, you know, envisioning a 2.0 for me, again, as a intermediary step, not as a long-term goal or a solution while we're fighting for greater capacity outside of what's in our own, you know, control, is as part of beyond the staffing study that we're doing. I mean, I think all of us are really hungry to know, like, what is the staffing number needed to maintain the mandated ratios, cover leaves and all of that at the ADC, you know, if we're at a goal or maximum capacity, right? And then the idea within that is with projects like Project Bridge, where we're relieving some of the pressures in the ADC of a certain type of population that can be successful in the correctional facility, then does that create physical space within the ADC for folks who are not able, for whatever criteria you're using as far as the ability to house them at the correctional facility, but to maybe address more targeted ways to providing behavioral, mental health, medical, substance use disorder regulation in a more compassionate way that's starting to treat the underlying concerns of those individuals. Again, that would never be the end goal. I mean, we want them to have treatment in community that's ongoing, sustaining, and addresses those issues. But while they're in our care, we can make that time of best service to them. So, I mean, imagining what that might look like in your space as well. Because if you're thinking about being able to manage, you know, complex detoxification times, or, you know, figuring out that regulation time, You know, how do we do that in a way that's gonna serve those residents, those individuals the best they can while helping your team like manage very complex and intense situations, right? And help in the best way possible. So Matt, I would love to hear, and some of that's just gonna be brainstorming and ideation, and you're gonna have like 5 or 6 things before you find out what actually is going to be doable. But if there's a way for us to create some space for that imagining, that would be helpful.
Excellent. Okay, Commissioner Young.
Maybe you have touched on this a little bit too, but you know, for the population size impacted by multiple decision makers, is there you know, what you had mentioned, like a decision tree and or a more complete like criteria to help make people inform those decisions?
No, so I'll just list kind of what, so we have law enforcement, city county attorneys, public defenders, defense attorneys, courts, social services, public health, community corrections, pretrial services, and community providers. And they all have an impact on that jail population. And so there is nothing that I know of where there is a collaborative effort that every one of those stakeholders is sitting at a table to say, here's what I can do, here's what I can do. This is the process of when you get to here, let's hand them off to me, you know, or you know, maybe there's something to do with if they're conditionally released. Maybe there's something in that conditional release, whether there's right before, because we put on like the AMP bracelets and then we release them out. Maybe there's something to do that we could work with the judges to say, before you do that, meet with this provider, and maybe it's not an immediate conditional release, but we figure out that handoff. And I think that is the big thing that we're missing is the handoff into this community. I always tell people, if I were to get arrested and somebody said, hey, go here, I'd tell you to go pound sand because I just want to be left alone because I made a mistake and I don't want to touch anything, you know? And so unless that trust is built, to know that we're there to help them get the help, they're just going to continue to not go to appointments. They're going to continue to miss court dates because there's not that value added when they leave that door. They're just, see ya, thanks for staying, you know, and I don't think that's the proper way to handle individuals in custody.
If I could add to that too, Ashley, I think that people, when they leave custody, they have things on their mind much greater than, you know, the medical appointment or the court date. Like they don't have a house, they don't have food, they haven't seen their family, you know, and so these are things that they just instinctively do before going to those appointments or connecting with the community to get the resources they need. They need to find a house tonight. They need to find shelter, you know, food, clothes. Those are the things that they need many times in their legal journey.
I appreciate that too. Do we ask them those questions before they're released at all?
But what do we do with them if they say yes? You know, we don't have those resources in place to, I mean, that would be a full-time job, I guess, as a correctional officer to say, hey, what do you need?
Yeah.
I'm not saying that's not a great idea, but it is resource intensive. But if we had a process and everyone had the expectation that you will pick up the phone when the jail calls, so we can get this individual being released to treatment, to a housing, so that they're getting released back into the environment that put them into the ABC. That's what we're doing for them. That's not helping recidivism at all.
Yeah.
Maybe that's where this collaboration really can, and maybe that's part of the 2.0 is we do have those things, right? We do have the transition services unit. We do have our community health educators that take that time to go over those things. And again, it's still not a catch-all, you know, but community resources that are coming in and sharing those and expanding on those as we build this collaboration. Because we do have those things and we do offer those things. And again, it's not a catch-all, but it's taking that time to go through that individual's needs. Because you're right. I mean, that's the first thing they think about is where I'm being housed. And maybe they don't want to go back to the same spot that brought them there in the first place, but they just need a place to crash for the night because the following morning social services opens or they have a contact that they can get maybe more stable housing. So maybe it's just for that night. And that's where community resources really help out. I just need a place to crash for the night.
Okay, I'm gonna be a advocate here because we're using good words like residents and clients and a unit, this is a facility. But they committed a crime, right? And most of the folks who are there who committed a felony, right? They have did something to harm, right? And so I just say that because we're talking about corrections. We're not talking about the health part of this. We're talking about someone who have committed a crime, a felony, right? Something more egregious, because what I heard and what I wrote down was like low risk offenders opt out. You try to house them in the community. You put a monitor on them, you release them up into the community, right? I don't know if we have any record of how many of those come back or what type of services are we giving to those individuals to make sure that they can be successful. So I'm thinking about that, if maybe we can get some type of report back of the success of those who are back in the community connected, low risk offenders who's not suffering from mental health or substance use disorder, right, or have committed a felony. That would be helpful. So as we close out, I'm going to just do a really quick of some of the things that I was able to capture. So the challenges at the ADC.
You're not done.
You're not done?
Slide.
Yeah, I've got one more slide. Okay, let's go to the one more slide.
Done.
All right, let's go to the last. Is there one more?
I think part of it is just being real in that if we want these additional space and then we want to take on these additional residents, that there's going to be additional resources and staff that are needed for that. Some units that have been
Is that for
closed.
this slide or the next slide?
Sorry.
This is kind of
So-
like section.
Some of the units that have been closed and converted would need to be remodified and made into livable housing units, right? And then on top of that, getting them staffed, right?
What have they been converted into?
So like, we have one dorm that when our population had dropped, was converted into where we do our Friday prayer. It's converted into a program space.
So what would
and
you do if you needed the coop space?
So if we did the coop space,
Yeah.
then we would open up our immediate housing units that we have available, like 200, like 11 or 12 or 1,200, and then start to build those back out again.
So are you saying if like tomorrow we had a coop situation, we need to move people in, you have spaces you've renovated that are not able to house people, right?
That we would have to house them just temporarily. It's not like that they're completely unlivable, but our bathrooms, right? Our bathrooms, that unit hasn't been used in years, and so we'd have to make sure that it's functional.
I guess then the more pointed question is the facility able to take 500 plus people tomorrow if it needed to, or did changes get made in between that?
Some changes have been made. I think we would be able to take them all, but it wouldn't be all in the bunks, all in the dorms like you'd see in 300 or 400 or in 1,300.
Okay. Thank you.
Mhm.
I mean, livable, habitable.
Yes.
Madam Chair,
Yeah,
if I may,
Commissioner Zhang.
I really appreciate the conversation and I just really appreciate, both, the openness about the challenges that you all face and experience in your two different facilities, as well as having a broader conversation about like what's possible working together and pulling in, the different departments, as well as different resources that we as a county have. Because Under Sheriff Bryant, like when you mentioned about like the spaces of like, those different departments and also the courts, county attorney's office. I swear there are so many of those spaces already, like some of those conversations happening already too. It's just a matter of
Bringing
like
it there.
leaving it together and pulling you into those conversations as well. Because at the end of the day, the county, big Ramsey County is
It's all of it.
responsible for the care of the residents. And when we don't work together, there are just going to be missed opportunities. And what we've seen too many times this year already is our, settlements and claims that have come before us. So I just really encourage us to work together. And that's why I did say like we should put some goals of working together as a big overarching goal, so that everyone is clear when they come to the table that that's what we're working towards.
One other thing, to back that up too, is just to remind ourselves that yes, the folks who are coming into the ADC have been arrested and charged with the crime. They're awaiting their trial. the people who are in the correctional facility at some point are going to have served their time and will be released back into community. Anybody in that system, the majority of the folks who either get arrested or have been after they've served their time are going to go back into our community. The bulk of folks will be. So in this moment of interruption, we have an opportunity to make sure that we are serving those individuals and their families in our greater communities for when they are brought back into our communities. So once you make a decision, once there's a bad moment in your life, it's not as if all of a sudden you are permanently removed from society and be done with you. That is not what the reality is for anybody who's coming through this system. And so we have an opportunity to use the time that they're with us to create an opportunity for success. And if there's a way for us to have that goal in here too, recognizing these folks are with us for a short period of time. It's a period of perhaps a positive interruption and intervening. How best can we serve the success of these individuals, because it will only benefit our entire communities. And we will see them again if we fail.
Yeah. So I would think those are all like great goals that we can try to do in partnership with all the other partners that we talked about, right? Because they are, I wrote down re-entry and returning, right? Because if we don't, I wrote down if they're off meds and they're not doing a Suboxone treatment, they may return, right? And how many returns are there because of substance use disorder or the mental health? So how are we more effectively partnering with, community-based organizations, those entities, right? This is like transformational work. This is not what, community corrections, public safety has often looked like, to invest into other people's lives this way. Usually they come in a certain time and you let them go and you're done, right? So this is really some transformational work that Ramsey County is doing. And, I talked about the words residents, clients, unit, facilities. Those are not often words that are used within corrections. So I appreciate bringing some humanity into those spaces, even under the challenges of what falls in there. You are saying we're going to see them through the eyes of being human beings. So with that, any more questions? I'm going to summarize. So some of the things that I heard, some of the challenges at ADC is the longer stays, the multiple charges, the egregious charges that you're seeing, the mental health, the substance use, the delays of the courts, Rule 20, which should be 30 days to be assessed, but sometimes it's longer than that for various reasons. Many courts hearings before a trial, jury, or a hearing takes place. These are all the challenges. Misdemeanors are short term over the weekend often, right? So those people are released back into the community. What I didn't hear was whether or not they get resources, right? Or what that looks like. What do we hand them off to and say, don't come back here again, higher safety concerns are held longer, which is like 1/3 of the population is at the highest level of safety concerns within. Project Bridge was created to address the overcrowding of ADC. So a partnership was created with the available space at the Ramsey County Correctional Facilities. And so the opportunities that we have found with the Project Bridge in the residents is the opportunities are the movement in the sunlight, the educational programming, the jobs programming that we're seeing, the learning center, the cultural programming, the financial incentives that you have created, the no cost and video visits that is happening. In 2025, 77% of the Project Bridge residents participated in these opportunities, which is awesome and great that number is high. And hopefully it continues to stay high and they stay engaged. ADC has a collaboration with the correctional health, which allows the Suboxone clinic to be there. You get dental services, medical clearance, mental and chemical services. You're looking into tracking behavior success, or maybe we add that for you to track behavior success and failures and et cetera. 72% of Project Pride residents receive mental health services. That is a lot. And so again, I just want to say thank you all for the partnership that you've created,
The next steps.
the humanity that we're seeing here within Ramsey County, in the work that we not just are doing, but we want to do into the future. And with that, I'm going to pass it on to Bonnie Manager Beckford to.
Yeah, I just want to thank the areas for collaborating and working together. I know we did this pretty quickly. Appreciate even just the sooner update to the board than waiting, too long. I mean, it's pretty fresh still. I think we had some more requests for some data and additional information. We'll follow up to make sure we get everyone's stuff and put it all through one email. And then I think we need to build a work plan, and I'll talk to our DCMs here on what Project Bridge 2.0 is going to be. And that's gonna have some goals, and also just kind of, I think, leveraging some of the existing tables where we should have conversations and, kind of layering what's the big ecosystem work, what's kind of the internal county work we can do. And I think, I just want to acknowledge, I appreciate what Commissioner Moran said about this is transformational. I do want to acknowledge both areas of community corrections and the sheriff's office have been doing transformative work. I think what we're really trying to push for now is how do you do it without a silo? How do you do it where the space doesn't hold you back, where it doesn't matter which door the resident came in on? And so that's kind of where the push area is in the transformation. It's not that we haven't been in lots of spaces, whether it's revocations and, bringing down populations and census, lots of things have happening, but I think what we're saying now is, how do we treat people holistically, regardless of which door they come in, using the full depth and breadth of all that we know in all departments so that people get the best of Ramsey County that we can deliver. So I think that's maybe the little bit of extra push I'd like to just kind of encourage you to think about, not just like, we're innovating over here. No, how do you innovate with everybody, right? And bring that best practice along. So, and not letting the space limit us. I'll just continue to say, resources are tight and we are not going to necessarily have new buildings and new spaces, but we have to be creative with what we have in the technology. And how do we make sure that the space isn't limiting like the work we can do? So let's keep thinking about that. So thank you.
Thank
Yeah.
Thank you.